Counties Manukau has embarked on a journey which is designed to improve the patient experience and quality of care using some modern technology. And over the last 6 months or 6 months of last year, we went through a detailed process of examining everything we do. Processes, interactions with the patient, management of information, and communication with the community, looking for ways in which we could help the management of patients and help staff do their job. We came up at the end of that process with 5 specific areas that we believed that we could work on and improve our patient journey. They were e-referrals and management of referrals, developing a medical ordering program, ensuring point of care information was available, maximising resource utilisation, and orchestrating the care that was essential for managing a patient. So we've got those 5 areas that we are now developing in more detail. In order to do that, we've had 3 teams of people over the last 3 months divided into 3 specific patient journeys. One of them is around cardiology, another one is a colorectal cancer patient, and the third one is a respiratory patient. And we've taken those patient journeys and looked at each of those 5 opportunities to develop a single view of how we can improve our patient journey.
I'm Brian, I'm a house officer at Middlemore Hospital. I've been working here for about 18 months and I've had first-hand experience about a lot of our actual processes on how we operate in the hospital. I guess a good opening summary is that probably over 50% of a junior doctor's time is engaged in a lot of manual processes, transcribing of information, mostly handwritten, and a lot of other manual things which slow down our work, such as pages, fax systems, paper everywhere.
The ward round is a good example of a complex decision-making process that involves multiple people and often at the bedside. When updating the patient's care plan or adding tasks, it's a manual process involving handwritten notes in the patient folder or medication chart. The problem is the visibility of that information. Often the folder is not where it should be, and you have to go looking for it, and this can take minutes that would be better spent doing other things. You might not be able to read the writing of the last person who made notes, or the pages are missing or not in the right order. When a decision is made at the point of care, for example to order a CT scan, there are 2 main ways we do this. The first is by sending a fax to radiology, and there are risks to doing this. For example, if you key in a wrong number, or the machine in radiology is out of paper, or if it just isn't seen for a while. The other way we do this is to physically walk it down to radiology. We did this equation to show how much time we spend each day doing this. If you're on the 4th floor in the general surgery ward, it takes 6 minutes to walk to radiology, times 2 for the return trip. Add 2 minutes for a possible interruption, like bumping into someone on the way or responding to a page, and 2 minutes to speak to the radiologist, or more if there's a queue. Times this again by 2, as you'll do this on average twice a day, and it's 32 minutes of a shift spent submitting a medical order or request. A reliable electronic system for doing this would be a major gain in efficiency and give us more time to do the things that are of real value for patients. A final example is that nurses have to write vital signs on a chart and manually calculate an algorithm that helps them decide whether to escalate the patient's care. Having an online system for this would mean the decision could be made quickly and the relevant care team would be notified immediately. The risk of delays or inappropriate escalation is reduced, and there is an extra layer of safety in the patient's care.
So what we want to do now is take you on a journey with a typical patient who has a number of the problems from each of these 3 clinical streams that we had. So this patient will represent a patient with a respiratory problem, a colorectal problem, and a cardiology problem. This patient is a fictional man who is 55 years old, he has obesity, he has diabetes, but he also has some cardiology problems and some respiratory problems. His main presentation to his GP was because he's had some bleeding, and he's concerned, and his GP is concerned, that he has a cancer in his bowel. He has a family history of this. Now we're taking this patient from a whole of system approach, from his primary care right through the hospital process and back into primary care. It's a patient journey, but as we discuss it, we'll be giving you the perspective of a lot of the clinicians and allied people and other disciplines who are involved with the patient in their journey. What you can see on this picture here is the complexity of some of our processes, which are very repetitive, very manual and prone to errors. What we want to move to is a circle of care where the patient is at the centre, surrounded by health professionals, and associated with this is an integrated system of communication between providers and the patient.
We start with Daniel's visit to his GP, and the GP is concerned that he may have bowel cancer. The GP refers Daniel for a colonoscopy and receives an electronic confirmation that the referral has been accepted and is in progress. Daniel is given a range of options for the appointment, so he can select a time that is convenient for him. He and his GP are kept notified at every step, and Daniel gets a reminder 2 days before his appointment, which includes important information about what he needs to do to prepare.
Daniel then visits the super clinic and has his colonoscopy, and the report from this goes to the GP and to the gastroenterologist, who can immediately refer Daniel to a surgeon if necessary. Daniel visits his GP, and the diagnosis can be discussed with him then, and he can then be introduced to his navigator, who is somebody who would coordinate his care and support him through the entire process.
Daniel comes back to the super clinic for his first appointment with a surgeon, and again has been notified that an appointment is available and he can choose a time that suits him. This is all done electronically to reduce the time it takes to do this basic interaction. At this stage, his care plan is activated, and Daniel's circle of care, which is a multidisciplinary team of health professionals, will be identified. They all have the information they need about Daniel when they are treating him or at the point of care. They can make the right decisions quickly, and Daniel doesn't have to keep repeating himself. Daniel can be referred for other tests, and clinicians can communicate to each other easily about his care. In many cases, the clinicians may want to talk to each other, but the important information is relayed quickly and efficiently in electronic form. At every stage of his treatment, he can clearly see where he is in the process, and so can his GP and others involved in his care. Daniel and his family also have information relevant to his condition and his treatment, so he knows what he needs to do at each stage. When Daniel comes to hospital for his surgery, he is welcomed by his navigator, who has all the information about his surgery to share with his family. When he is admitted, his details are checked electronically by members of the care team and can be updated on mobile devices, so they're always up to date.
Daniel then goes into surgery, and at the completion of surgery, his family can be notified that he is in the recovery room and when they can expect to see him. When he is ready to be transferred back to the ward, an orderly can be notified electronically, and an electronic handover or transfer of care takes place between the staff in the anaesthetic, in the post-anaesthetic care unit and the ward. And Daniel is moved up to his ward. In his room, there is a screen which shows him his care team with photographs and the types of treatment that he's scheduled to have, and this is updated on a daily basis. Over the next few days, several ward rounds take place, and all of the people involved in Daniel's care will visit him to carry out their part of his treatment. All of them have up-to-date information available at the bedside to assist them in decision-making in his care. If any further tests or procedures are required, Daniel can be easily informed about these, the time they're going to take place, and what he needs to prepare for them. He understands that his hospital stay is no longer than it needs to be. Daniel is now ready for discharge. And this is the transition of care back to the community. And there are a number of elements to this. There is the electronic discharge summary, and there's a prescription, and his discharge may involve a transfer to a discharge lounge. One of the things that we're looking to introduce is electronic prescribing, and the advantage of this is that the medical staff, with their secure login to the system, can prescribe from anywhere in the hospital, so that Daniel doesn't have to wait for a doctor to physically come and see him to sign his prescription. The prescription can be sent electronically to the community pharmacy, who is notified of his discharge and will note the dispensation of his drugs. Daniel's GP is also notified of his return home and receives a discharge summary. The same summary is sent to all those involved in Daniel's circle of care in the community, so that his treatment after hospital is coordinated, and his navigator continues to support him through all aspects of his care.
Following on from discharge, there are a number of possible stages in Daniel's treatment, including follow-up appointments with the surgeon, treatment at the cancer clinic, or a visit to a respiratory physician or a diabetes clinic. Referrals and medical orders are done seamlessly. Daniel and all members of his circle of care are informed at every step, and the process is efficient. The important steps are done electronically, and Daniel has the personal support he needs. The surgeon or other clinicians can offer appointments at the most suitable location and time for them, and from there Daniel can choose the times that suit him. Schedulers can contact Daniel to make changes if they need to, and they can quickly ensure they have everything they need for his appointment.
So that's the end of this part of Daniel's journey. Where we are in the process now is that we are looking at various potential solutions, electronic solutions for these areas that we've identified, and seeing how they can supply the IT solutions that will support the model of care that we have. We'll be developing business cases which will go to our board for further examination there.